Okay, great. Sounds good.
So you got us on YouTube as well?
I'm sorry.
You got us on YouTube as well?
Yeah, I think the audio is sort of cutting in and out. I'm not quite sure why.
My audio, can you hear me?
I don't know if it's your audio or if I'm mishearing it or not, but something is sort of cutting in and out. Not quite sure why.
Okay, I was asking if we are on YouTube as well.
Yes, I have it up on YouTube here. I don't know if I can invite you somehow now that it's live.
Probably not because I'm only on one device.
Okay, sounds good.
Okay, well, I like I was saying earlier, I'm not sure. Like I was saying earlier, I'm really grateful to have you. This is something new that I do for my platform that I think is going to be very helpful to the mental health community. And with that in mind, I am going to ask what made you decide in a career of mental health?
That's a great question. When I was in college, I actually majored in economics. I didn't major in psychology, and I worked at a hedge fund over the summers when I was in college, and that was okay. And then when I graduated and I started working kind of for the rest of my life, I had a hard time wrapping my head around the idea that that was going to be forever, and I just couldn't see myself doing it. Um, and I really took some time to kind of think about what I wanted to do and what I thought I would be good at, and how I could contribute to society in a positive way. And actually, I remember I was actually on a bus ride from Boston to New York, um, sleeping on the bus ride, and it just hit me, and I said, you know what, I'm doing this. I'm gonna love it. I'm gonna be good at it, and I went for it. So
That,
that's sort of how it happened.
that sounds pretty cool story and a good experience. It's like when you know you're passionate about something, you know it and you go for it. That's awesome. And what made you take on TikTok platform? Like why TikTok?
So I started with Instagram, and then someone mentioned TikTok, and I said, "Oh, that sounds great." Someone told me that I think I heard a couple things. One was I heard that TikTok is, getting really huge, was one, and the other thing that I heard was that a huge percentage of the medical information that's put out on TikTok is untrue. And that kind of concerned me also. So I said, okay, let's put out some proper, correct information and, help some people, hopefully.
Yeah, I watched your videos and I watch them all the time and I think you have um, amazing information. It's like you fill in so much information in one video. It's like a whole book in those 60 seconds, and that's pretty cool. That's pretty cool. I like that on your platform. Um, and can you please tell us a little bit more about psychology? Yes. What is neuropsychology?
Great question. Neuropsychology is it's the study of essentially all neurologic conditions that affect a person's thinking skills or behavior. So, and that can be anything. It can be a disorder that generally first initiates in childhood. It could be something that onsets much later in life. It could be head trauma. It could be stroke. So basically, anything that can happen to a person's brain that will affect their ability to think and behave. Um, I guess, quote unquote, normally, that is what neuropsychology is. So a clinical psychologist is sort of like a cognitive neurologist. So it's essentially um, a, a neuropsychologist is a clinical psychologist with expertise, again, in those conditions that affect thinking skills and behavior. So a lot of times people ask me, well, isn't that all neurologic conditions? The answer is no, because there's a lot of neuromuscular conditions that don't affect thinking skills and behavior. So, for example, peripheral neuropathy, theoretically, ALS, again, theoretically, does not affect a person's thinking skills and behavior, though it's a very complicated question. Um, so, yeah, my focus is basically from the neck up.
Okay, that sounds cool. Um, so by doing this, is I have a question on my own that wasn't on the paper that on the draft that I came to. How important is for a person that it's, I will say, battling, because that's what we just do, battling depression, anxiety, and a mental health illness, a mental illness. How important is it for that person to educate themselves about the parts of the brain and what is affecting them? Like, how important it is, and what is the easiest way for somebody to get all this knowledge without going to the school, but actually still understand that brain and body are so connected together. They are one package.
Yeah. So, I mean, really, I think it's crucial. If a person is suffering from depression, from generalized anxiety, panic disorder, any of those sorts of issues, it's very difficult to overcome them on your own without understanding what you're trying to do, right? So, I think that if you pair with a good psychologist or psychiatrist, they can help you understand what things help pull a person out of those sorts of situations. Um, it just helps the process dramatically. So that's why therapy is important. That's why just having a doctor that is very knowledgeable and can tell you what things are going to be helping you kind of speed up the process of healing. Um, it can mean everything.
Right, right. And does a neuropsychologist prescribes medication? Do you prescribe medication?
So my job mainly is to tell. I sort of act like a consultant to a primary care physician or a neurologist. So mainly what I do is I tell the prescribing physician what I would like to see prescribed for their patients in order to help them function at their best. So sometimes for people with Alzheimer's disease, for example, the classes of medications that are that have been around forever are the cholinesterase inhibitor and the NMDA antagonist. If I would like to see a patient on an antidepressant, a lot of times we'll have a very specific conversation about what antidepressant I would like to see prescribed and why. So I sort of act in my capacity as a neuropsychologist, I act like a consultant to the physician after I meet with a patient and evaluate them and let the primary care physician know or the neurologist know how I'd like to see things handled from a
Right,
medication standpoint. Yeah.
right. So since we are in the medication area and a lot of us have a lot of questions, I'm gonna sit a little bit with this topic if that's okay with you. And
Absolutely.
then,
Anything, anything, anything.
oh, thank you so much. So how long does it take for an antidepressant to show improvement? Because I do have a friend that is very uncomfortable with antidepressants and changes it very quickly, doesn't allow one to sit with it. So because I'm sure it's scary, the unknown and everything. So how long does it take for an antidepressant to show signs of improvement?
Yeah, that's a really good question. So, when we use the term antidepressant, that's a very broad term. So, an antidepressants over time have gone through a number of changes. So, initially, the first antidepressants were called MAOIs, monoamine oxidase inhibitors, which are prescribed less frequently now unless a person fails trials of newer antidepressants. And the reason for that is because they can be pretty effective, but they have a lot of side effects and they interact with a lot of drugs and foods even. The next generation was tricyclic antidepressants, which still are prescribed these days. They can be effective for migraine and for sleep and for a lot of other issues. And they're also very effective, but they don't have the greatest safety profile in terms of side effects. And then the big breakthrough was the SSRI. And when most people think of the antidepressants these days, that's what they think of is the SSRI, the selective serotonin reuptake inhibitor. And when people ask me that question, usually, or when anybody asks a doctor that sort of a question, generally the assumption is they're asking that question about the SSRI, and uh, most of our audience has probably heard of different types of SSRIs. So, for example, Prozac, Paxil, Zoloft, Lexapro, Celexa, those are all the SSRIs. There have been more medications that have come out since then, more antidepressants that have come out since then, namely the SNRI, which is a selective norepinephrine reuptake inhibitor, which is considered an atypical antidepressant. But assuming we're going back to our discussion about the SSRI, the company line is that it can take anywhere from 2 to 8 weeks for an SSRI to begin working. Um, but everybody's different. I've seen it work much, much faster than that for certain people. If by 8 weeks it hasn't helped a person show some improvement, then generally speaking, it may not be helping as much as we want it to. But you really have to give it at least 8 weeks to kick in. And if by that point there's no improvement at all, then that may be an indicator that it's not really working.
Okay, wow, great answer.
Yeah.
So like I said, I'm gonna stick with the medication question. Um, what? Okay, so for a person that hasn't tried medication yet, right? And it's the first time trying medication, what are the signs, all the improvement that they can look for? Because a lot of times, um, I see people looking for, like, I don't know, that picture happy. Like they think I'm going to take this pill and in 4 weeks I'm gonna be Superman or Superwoman, or they expect some changes, right? That we get confused exactly what are the changes, the changes we are looking for. So what is that we have to look for with the medication? Like something that that be like, okay, I feel different.
Okay, awesome. Yeah. So that's a really terrific question, Aura. So um, one thing I want to stress to people is that an antidepressant is not a happy pill. It's an antidepressant, right? Meaning the goal is for it to make you not be depressed. Thereby, once that happens, that very frequently allows people the opportunity to be happy, but the medication itself does not make you happy. So the goal is for it to be an antidepressant. And again, like we said, it takes somewhere between 2 and 8 weeks for it to start working. It's not that you're going to wake up one day and say, oh, it finally kicked in. Now I feel it. I can feel it doing what it does in my body. Because honestly, the first week or 2 weeks that you take it, you're going to take it and you're not going to notice anything at all. It's going to feel sort of like you took a vitamin, for example. You took it, you don't notice anything, nothing happens. And that's assuming you don't have any side effects, hopefully. So after a couple of weeks, as time goes on, what happens generally is if you can stop and look back and say, you know what, like I haven't been feeling quite as depressed as I remember myself feeling a couple of weeks ago, a few weeks ago. Um, it's not a happy pill, but in helping you be not depressed, it can be really effective in giving you the opportunity to make yourself happy. Hi there. um, so the other thing that, yes, Little Wolf, that's a good point. You do need to make changes in lifestyle as well. Um, the other thing that I would like to stress about it is that, the way that I like to explain it is that, we people in our lives, we have ups and downs and peaks and valleys. We have good days and bad days and good times and bad times. We experience anger and fear and sadness and happiness and elation and all these different emotions. So what happens for people that suffer from, these are really good questions. Are we like making note of them somehow? Okay,
Yes,
good.
I have here my assistant. He's taking the questions for us to address them at the end.
Oh my, I need an assistant. That's awesome. Okay, so um, we have good days and bad days and ups and downs. So the antidepressant, when it's doing its job the right way, it doesn't change any of this sort of up and down. It doesn't alter your day-to-day happiness. what it does do, so for people that suffer from depression, sometimes when people fall down, they just fall really far down, right? So
Right.
there's the up and down, and there's a huge drop, and it can be really, really hard to climb out of it. So the antidepressant, when it's working correctly, doesn't change any of this. You're still going to feel anger, and you're still going to feel sadness, and you're still going to feel the full range of emotions. But what it does do is it fills in those deep holes so that when you do fall, it'll catch you, right? So that you can get up and kind of keep going and living the life that a person who doesn't suffer from depression lives, if that sort of makes sense.
Oh yeah, that makes sense. I mean, you give me a total different way to look at it, so that's awesome. Um, how would a person that's on antidepressants express their concern about the side effects, right? Because I believe that every medication has a side effect, more or less. And I mean, a lot of antidepressants, when you look online, they have a bunch of, side effects. And how do we bring that up into a discussion with our doctor in a way that will make us not feel like I'm 100% against it, in a way of like, genuinely, I'm concerned about this. How can you help me understand it?
Yeah, great question. So you nailed it. That's perfectly correct. Every medication that is prescribed that a person puts in their body, every medication has side effects because they work systemically and they go throughout your entire body. Every drug has many effects. There are no silver bullets. Unfortunately, there are no silver bullets, right? So every drug has many effects, and very frequently people do experience a lot of side effects. Thankfully, generally speaking, with the SSRI, as we were talking about, the selective serotonin reuptake inhibitor, the safety profile tends to be pretty good, especially relative to some other psychiatric medications. There are some black box warnings for children and adolescents, but generally speaking, the safety profile is very good. The most common side effects that people experience with SSRIs are upset stomach, which is with almost any oral medication. That tends to pass within a few days to a week if a person sticks with it. One of the most common complaints that people have is a sexual side effect. Some people complain that it can be harder for them to achieve orgasm when they're on the medications. But again, that too, if you stick with it, that tends to improve over the course of time. Um, but when you're experiencing these side effects, I think that, to an extent, you have to see your doctor sort of, they are your friend, but they're not your friend, but they are your friend, So it's
Exactly.
like,
Yeah.
you know what I mean? So you need to have an open conversation and say, look, I believe in this. I believe this is going to work for me, but I'm experiencing this side effect. What can we do about it? I'm not saying, just like you said, I'm not saying that I want to come off of it, but I'm experiencing this. What's going to happen? And that doctor should be expert enough to say, okay, let's do this. We're going to lower the dose while your body acclimates to it. And then once you've been on it for another couple of weeks, let's try, bringing it back up the levels in your system. Or they might say, you know what, this may not get much better in terms of this side effect. So if you don't think it's something that you can live with, let's try something else. Or they might just say, stick with it. You're going to be okay. That's going to pass within a few days. So I think that to a huge extent, as strange as it sounds, you need to have faith in your doctor, sort of like a friend would. And if that is not happening, then it may be time to look elsewhere if you don't have that feeling.
Right. Awesome. Awesome information. Um, so let's say for an inpatient mental health treatment, what would be your most comfortable advice that you can give to somebody for the plan of exit? I mean, in inpatient, yes, we prepare you with a psychiatrist on an appointment, with a psychologist if you don't already have one, you know. But what is one thing that you think it, besides those two professionals that can help you? What do you think is very important to remember and very important to have in your toolbox when you get out of inpatient mental health treatment?
Sure. So I think that the number one thing in my experience is social support. Just to, feel like that there are people on the outside that are waiting for you and are going to support you as you acclimate to kind of the reality of what just happened, and all the things that led you to the point where you were in an inpatient psychiatric hospital. People that are going to help you make sure you take your medication if you're not feeling like yourself. um, People that are going to help you and make sure you eat, people that are going to help you and make sure you exercise, because that's crucial as a person is recovering psychologically. If I'm going to say there's one thing, it's social support, close friends, family, people that love you. Um, it's just crucial. Um, that, in my opinion. But with that being said, I think the answer also varies wildly. So if you have a person that is hospitalized because of severe depression rather than a person who's hospitalized because of schizophrenia, that's also a very different situation. So a lot of times, um, if a person is hospitalized for depression, they might be in the hospital for only a day or two before they are released. And some people with schizophrenia are in the hospital for months. So a lot of it depends. Um, a lot of times people are set up with psychiatrists or nurse practitioners that they're not comfortable with when they leave those facilities, and that leaves people with sort of a huge gap in their care. Well, okay, now what I do? So I look for another psychiatrist, and the wait list is 3 months and it's $400, and I can't afford that. So I think, again, going back to my original statement, it's having family or other loved ones and friends that can help you navigate that when you're not at your best is pretty crucial.
Right, right. I think that was a good answer, and also very important to build your community around you to be able to help you. That is very important. I agree with that. So again, I'm going to ask a question that I do not have on the paper, but you let
Please.
me know if it's something that you can answer. If not, we pass and we go to the next. Um, I have a question about complex post traumatic stress, CPTSD, and from the research that I've done, I need to understand that complex post traumatic stress is not in the DMS-5 yet, unless I'm not aware of it. Do you know if it's in the DMS-5 or no?
It's not in the no, it's not in the DSM. No.
Okay. And that it's because I know that complex post-traumatic stress has come to the surface and has been labeled as complex childhood trauma. Just like what, about 5 years ago, maybe it's gotten into discussion and people are talking about a little, maybe a little bit more than that. I don't know. But okay, that's thank you for the answer because I've been looking for somebody professionally to tell me if it is or not because I did my research, but I'm like I can't find it. Um, so would you be able to explain to us or give us a rundown about the difference from PTSD and complex PTSD, complex post-traumatic stress?
Well, so before I say that, there's one other thing I wanted to touch on that I think is pretty important. So, the DSM, which is the Diagnostic and Statistical Manual for Mental Disorders, is sort of like a big book that describes every psychiatric disorder that a person can have. So, we're now on the fifth edition and a text revision of that edition at that. So, we've been through many iterations of it, and um, it the way to look at it is sort of, you know we kind of understand the human psyche more and more as the years go by, and the more we understand it, the better we can do research into it. So if you go back to the first DSM, um, many years ago, it basically classified things as neurotic or psychotic, and that was like everything fell under those categories. And then the next one, it got a little bit more complex, and all the way into, it's unbelievable, but all the way into the 1970s, basically the DSM classified being gay as being a psychiatric disorder, which is pretty unbelievable. So it's constantly evolving. As we learn more and more about these things, the creators of the DSM, get a little bit better and a little bit more accurate um, with a lot of these things. With PTSD, so can you restate your first question about?
It, my first question, if you can do a rundown for us the difference between PTSD and complex PTSD, complex post-traumatic stress. I'm sure that a lot of my viewers that are on this platform know pretty much the difference, but I think it's very important to do a refresh on that.
So complex PTSD, the way that my understanding of it has been, and the way that um, I've seen it a couple of different ways. I've seen complex PTSD as when it's diagnosed with some other psychological disorders. I've seen it described as complex PTSD. I've seen when it arises from uh, stressors that are not quite clear. I've seen it described as PTSD. I've seen it when it arises from something that happened many, many years ago. I've seen it described as complex PTSD, and I've seen it when it's combined with substance abuse. I've also seen it described as complex PTSD. So, um, the way that I see it, it is kind of a broad term, but in terms of PTSD itself, post traumatic stress disorder, typically by the textbook, right? So the actual diagnostic feature of it is that a person will have experienced some kind of a traumatic event in which they felt in some way that they were in danger, their lives were in danger, they were in danger emotionally or psychologically. And the common symptoms of PTSD include daytime flashbacks about that event, nightmares, hypervigilance, which is sort of means that a person's always on edge, being afraid of situations that resemble the stress that a person, right, like our military vets. So, coming into contact with stresses that resemble what a person has been through. So those are really kind of the textbook symptoms of post-traumatic stress disorder, but I have seen complex PTSD described in a number of different ways. And I think people experience it in a number of different ways also.
Right, right. And I think that the one thing that is hard for me, and really even hard for me to put into words, to know how to describe what I feel, like the sensation, the irritation, right? Um, I think that the emotional flashback of it, because from what I read, PTSD is a lot of visual, a lot of hallucination, and finding yourself like feeling like you are there. Complex post-traumatic stress has the same criteria, but it's more of an inner feeling, like the emotion of the moment. So, thank you so much for explaining that to us.
I mean, and
Uh,
one thing I'd add is just that it that sort of seems to be at the core of PTSD is this feeling of reliving whatever it was that happened, right? So if it's a daytime flashback, it's almost like you're reliving it. It's like it's happening all over again. Or if you're having a nightmare, it's the same thing. It's just you're asleep. When a person tries to avoid, different environments that remind them of the stress that they were through, it's just them trying to avoid that intense feeling again, like they're being re-traumatized all over again.
right, right. And I have experienced in the past 5 years, I have experienced many, maybe too many emotional flashbacks, and they are extremely scary because I am at a point in my healing journey where I can identify what it is, but I'm not identifying prior things. I cannot point the trigger before it puts me into that, into that wave pool, right?
Yeah.
So I think that it's very important to learn how to identify the trigger before you put you into that emotional flashback. So
I mean,
yeah,
and one other thing I'd add to that, if I could, it's just that With PTSD, it's a tricky issue because with a lot of psychological problems, there's a right way to deal with it, and everything else is the wrong way. So, for example, when a person is suffering from panic attacks, a lot of people don't realize again that it's assuming that your heart is healthy enough and that you're healthy enough physically. The proper treatment for panic attacks is not to try to escape it and just put your head between your legs or breathe or whatever it is. Breathing can help, obviously, and it's a good thing to do, but the proper treatment, the research shows the best treatment is exposure therapy. With PTSD, it's much trickier because there are some people that can do well with exposure therapy, and there are some people that it would make things a lot worse. There's some people where, believe it or not, as crazy as it sounds, distraction, getting really effective with distraction can be the best thing for them to do. And then there's a lot of people that argue in favor of EMDR, and there's a lot of people that say EMDR doesn't work. So PTSD is it's tricky, but people really get through it. I've seen countless people get through it. So people heal.
Right, right. So you mentioned EMDR, so I'm gonna first ask a question because I know that EMDR again haven't been into the world for long, and a lot of people doesn't have as much information about it. So would you please tell us a little bit about EMDR and what looks like, what it does for us, what it can do for us, if
Sure.
you can.
Yeah, EMDR is a treatment that's specifically for post-traumatic stress disorder, and it's controversial just in that there's research that shows that it works really well, and there's research that shows that it doesn't work. And the people that buy into it believe in it wholeheartedly, and the people that don't believe in it, feel just as strongly that it doesn't work. So EMDR involves the basic idea of it is that a person talks through and re-experiences the trauma that they went through, but they do it while they're going through a process of shifting their gaze, generally speaking, from left to right and left to right. So sometimes that's done simply just by following a person's finger. Sometimes there's these complex machines that send a light back and forth that a person tracks with their eyes, and the theory doesn't really work out anatomically, meaning if indeed it does work, which again, many people feel it does, if indeed it does work, we probably don't have a great understanding of why, in terms of brain function, it truly does work. The people that believe it does say it's because it has to do with different parts of the brain communicating with each other, and parts of the right side of the brain and the left side of the brain communicating as your eyes shift back and forth. But it doesn't really make sense anatomically necessarily. That side of it, at least, I don't buy into. If indeed it does work, I don't think that's necessarily the reason why. I think we probably don't understand well why it does work. Um, but there are a lot of people that swear by it.
Yeah.
Yeah.
I think that the part that has been presented about EMDR a lot, and I've seen this information, is and what makes us happy and want to try it is because they say that you don't have to talk about your trauma as much. If one moment you pick one moment, they do the back and forth thing with your eyes. I'm just gonna say it my way, and
Yeah.
then apparently you after that appointment, you feel more light about it and it doesn't affect you as much. So, from this question, I am going to ask, in your opinion, and I know that it's not every shoe fits all, but from your experience, what kind of approach has been more successful into mental health, into childhood trauma treatment, mostly because my platform is about childhood trauma?
Sure. And are you asking specifically about PTSD with childhood trauma, or just general psychological problems relating to?
Let's put a general into it. Yes.
If we're talking from a talk therapy standpoint, obviously we're not talking about medication, um, right? Because medication doesn't fix childhood trauma, obviously. But in my experience, cognitive behavioral therapy is most effective. When you go to school to become a psychologist, they teach you many different ways to treat different psychological problems. There's psychodynamic therapy, which essentially is kind of old school psychology, dealing with your childhood and going through it and working through it and understanding it and having a better understanding of how it affects you and who you are. Um, what is much more popular these days, because the research supports it better, is cognitive behavioral therapy. And cognitive behavioral therapy, at its essence, is sort of, when a person suffers from a psychological disorder like anxiety, something happens in their lives and they perceive it a certain way and it creates anxiety, right? So, what cognitive behavioral therapy does is it takes that same experience and it teaches a person to look at it and start to perceive it a different way so that it doesn't create that immense anxiety or stress. Meaning, so you just start to perceive your environment as a less dangerous place. It deals with the here and now rather than your childhood. And the truth is, the research shows that probably, and I'm sure that there are psychodynamic therapists that are, throwing their empty soda cans at the screen right now. But if you do look at the wealth of research, it's much, much more in support of cognitive behavioral therapy than psychodynamic therapy.
Right, right. And what, so what other kind of therapy, like from the top of your head, you can think about to throw in our conversation? Like we talked about UNER, CBT, what was the next one that you
Sure.
mentioned?
There's dialectical behavioral therapy, there's interpersonal therapy, there's rational emotive behavior therapy, there's gestalt therapy, there's solution focused therapy, there's existential therapy, there's client centered therapy, humanistic therapy. It goes on and on and on. So, um, generally speaking, the most popular one is cognitive behavioral therapy. But, I think a good therapist has an integrated approach and understands when one approach is going to help a person and can shift gears from one to another, even within one session, if that's going to be what is most helpful for a person.
Right. So being on this topic with therapists, when would a person feel that maybe the connection is not there and something is not working? I'm going to um, and tell you how I felt about therapy first time. So I joined therapy. I had no clue what therapy was. I was going through a very hard moment in my life. My mom passed away, so my depression took over completely. Like I was down to the ground. There was no way more down for me to go. So, I did contact a therapist and I contact a psychiatrist, right? I was doing all the right things that I knew to do. And the first week was extremely hard for me to open up to her. Like I was talking about the whole abuse of my mom. Like I knew my mom's abuse from my father through the book, but I never talked about what happened to me. After a year, I found something happened, and we just clicked together, and that's when the hard work started, right? But I was ready to like kind of this is not going. I didn't feel like I was getting enough out of it. So with that story, when does a person detect either it's not working or it's working, or how to approach that issue with the therapist in less offensive or helpful for the therapist and for the client?
Sure. Yeah. I think that any time that you're feeling that way as the client in the therapeutic relationship, it's always okay to have that conversation with your therapist. And if your therapist has a hard time having that conversation, I mean, a therapist's job is to have hard conversations, right? So if you try to have a hard conversation with them about the fact that you don't feel like you're progressing and they have a hard time with it, that's a problem in and of itself, the fact that they don't want to have that conversation. So you should feel comfortable having that conversation anytime you see fit. And by the same token, I think a good therapist can also be able to say, look, I want you to get better and it doesn't feel like you're getting better the way that I want you to. Um, do you want to talk through that and see how we can fix that? Or do you think maybe that, you want to see if I can help you find someone that might be better at helping you kind of get to where we're trying to get you? So, you know, good therapists have those conversations sometimes. In my experience, if I've ever had those conversations, usually the response I get is, I don't know what you're talking about. I am getting better. so, um, but I think as the client, um, you should feel comfortable asking that question at any time. Again, it's a therapist's job to be good at having hard conversations. And if you bring that up and they have a hard time having that hard conversation, then that's a whole big issue in and of itself. So don't ever feel shy about having that conversation. The other thing that I think I'd bring up is knowing when it's time to start and try medication, right? When the therapy maybe would be working better if you were on a medication. There's a time for medication, there's a time for not taking medication. So generally speaking, my criteria, this is like a very loose criteria, but basically the closest I can come to putting it into words would be, I believe a person should be a candidate for an antidepressant in two main scenarios. One is if they've had multiple episodes of depression. So the research basically says that if a person has had one episode of depression, there's a 50% chance they're going to have another one at some point in their life. If they've had two, there's a 70% chance. If they've had three, there's a 90% chance. And if they've had four, then it's almost certainly going to happen again unless they take medication. Because at that point, you're starting to realize there's likely some kind of a biological / genetic component to it. So you fight biology with chemistry, with medication. The other time is when a person is suffering from very severe depression and they're having thoughts about hurting themselves. At that point, you throw everything you can at it because it's in a dangerous place and you need it to get better. So those are really the two main situations in which I say it's really time to start talking about medication.
Right, right. Um, Good information. I'm like a sponge. Get all that information,
Good.
and I'm sure our viewers are, finding this very, very insightful. Um, so, one thing that since I'm very passionate about mental health and also myself battling mental health, um, one question that I've been having about is the communication between a psychologist and a psychiatrist. And I was talking on a live with Dr. Um, Paul, uh, really, really good person, amazing life. Um, and he said that you can actually request for your psychologist and your psychiatrist to actually talk, right? Which I I did not know that. But my question is this: why is this not a thing? Like, do you think it should be something that everybody should know is a possibility? And do you think it would be helpful for the person that reaching out to psychologists and psychiatrists for them to work together in order to manage medication and also like hand in hand?
Yeah, 100%. I mean, that's like a hard stop. Yes, period, a hard stop for sure.
Yeah.
Your psychologist and psychiatrist should be working together with the following caveat. So, just to clarify, if there's anybody watching that doesn't know, generally speaking, and again, I'm coming at it from a slightly different standpoint because I am a clinical psychologist, but I'm a board certified neuropsychologist also. So that means I have a lot more medical training than most psychologists. But with that being said, for those of you that don't have a lot of experience with it, psychiatrists typically prescribe medication that they do. Psychologists typically do talk therapy, and there's exceptions to that because there's a lot of states in this country now where psychologists can't prescribe medication with the proper training. So yes, definitely they should work together. I would say the exception to that is if it's uncomplicated. In other words, uncomplicated in a number of different ways. So, for example, you have a person who is suffering from a depression which is clearly biological, like there's a strong family history and there's not a clear stress that they're reacting to. And, the psychiatrist is not conducting any kind of therapy. They're just taking a medical history and a background and prescribing a medication. The psychologist sees what the medication is and that makes sense to them and they're in agreement. Then there doesn't necessarily have to be this complicated ongoing coordination that way. But with that being said, in many, many other cases, they should be in communication, and you, as the patient, absolutely have the right to request that they be in touch. You just have to sign a release of information um, and say, hey, can you touch base with my psychiatrist or can you touch base with my psychologist? Just so I make sure you two are on the same page. Yeah.
Right. And so, still sitting in this area with another question, um, when when does the person know when it's time to come off?
I'm sorry, what it's time to?
When does a person knows that it's time to come off of an antidepressant? Because, like, okay, so when do you feel like, okay, I think I'm doing better and I can come off of it? And how do you approach that to your psychiatrist to not him not look in a corner and be like, why do you ask that? Like, how do you bring a conversation with your psychiatrist about that?
That's a good question. Um, so my rule of thumb is that if a person's on an antidepressant, I always start the conversation by saying, um, you know, yeah, I need you to make me a couple of deals. We're gonna get you on this medication. I need you to make me a couple of deals. One is that you're gonna take it every day at around the same time, no matter what. You're not gonna let the medication run out. If you have only, a few days left of the pills, you're going to make sure you get it refilled so we don't have a lapse, because if you do not take it every day, it's not going to work for you. That's one of the deals. And the other deal is that you're going to agree to take it for at least 6 months, right? Because of the fact that it can take up to 2 months to really, really start working, which most times it doesn't, but let's just, for the sake of this conversation, say that it can take up to 2 months. You really want to be on it for at least 6 months to really, really know over some period of time how you respond to it. Um, and then if people come back after 6 months and say, hey, I'm doing pretty well, maybe let's talk about coming off of it. A lot of times my response is, well, if you're doing so well, then why should we talk about coming off of it if things are going well for you? Obviously, there are circumstances if a person wants to get pregnant or other issues going on, but um, 6 months is my kind of point at which I think a
Right.
person should at least 6 months. And then I think, just like we have been saying, I think that, psychologists and psychiatrists, it's their job to be able to talk about anything. Talking is what they do. So
Right.
if you feel uncomfortable raising concerns about your medication or raising concerns about the therapeutic process or your progress or anything like that, I think that to start out with should be a topic of conversation that you work through. The fact that you're not comfortable bringing certain things up so that you can
Right.
work through that. And if that doesn't fix your concerns, then it may be time to start looking elsewhere.
Right, right. And I think that's a very easy way to bring a conversation like that. You can do it either through an email, through a little note, and give it to the person at the end of the meeting. And that is a very helpful way how to bring the conversation in the next meeting. So,
Sure, you can do that.
right. So I just want to tell everybody that we have two more talking points, and after that, we are going to take your questions. So if you have any questions, please leave them in the chat. Pat is going to note out the questions for us, and he's going to address them at the end. Um, so my next talking point is, what are your expectations and hopes for ADHD therapy? Like, what are your expectations and hopes?
I'm sorry, what are my expectations for?
What are your expectations, hopes for a patient in therapy?
So, it's really interesting. When I was in school many, many years ago, obviously many years ago, when I was in school, I had a really good teacher who taught us my first year of school. Of my doctoral program, we took a course called individual psychotherapy. So, he told us, this whole story about this couple who were having a hard time getting pregnant, and we're talking about how it was, the fact that they couldn't get pregnant was negatively affecting their relationship and their sex life in general. And then, talked about how the therapist came back into the room the therapist came back into the room after talking to him for a little bit, and he said, "You know what, you guys need to just go home and just do it." And and it was, and I think like the point was that therapy is different for every human being. So um, I think that, obviously my goal as a psychologist is for the patient to meet the goals that they want to meet. But with that being said, I generally don't go in with specific goals other than what my client or patient wants, right? So um, I'm not trying to achieve something that my client does not want to have achieved. In other words, so it's very, very different based on the person, and that's why I also don't say you'll hear a lot of psychologists say, "Well, I'm a cognitive behavioral therapist. Well, I'm an interpersonal therapist. I'm a psychodynamic therapist. I don't consider myself, I have training in all of those, but I don't consider myself any one of those because I don't go into any therapeutic relationship with an expectation that I'm going to be doing X, Y, or Z because everybody needs something very different. You have two people that are the same age, same height, same weight, from the same place, have had the same life experiences, and have the same psychological issues. They might need very, very different approaches in order to help them grow. So it varies. That's what I'd say.
Right. So, one more question in closing before we take any questions. If you guys have any questions, please send them in. Um, we all are born into this society where the picture of happiness, right? We are all, everybody's confused what really happy feels like and what really happy looks like, right? And because we are born in this society, we look at happy as, okay, happy is having a family and a house and a good car or a good job or like all that. Um, from the point of, from this side, as a survivor of childhood trauma and as a person that battles mental health, um, it was very confusing for me. Like, where am I going? Where is my direction to happy is going to be? Right, very confusing for me. Um, so here comes the question. Realistically, having a mental illness, is it a cure or just learning how to cope with your mental illness?
Hmm, okay. All right.
Because
I got.
it's like I'm gonna reach the button and I'm gonna get past that finish line and I'm gonna be cured. And a lot of us doesn't even know what really is going to look like, right?
Mhm.
So talk to me about that.
Okay. So I have a very long-winded answer for you.
That's
So
okay. We have time.
we in Western society put a lot of emphasis on happiness, right? Everybody wants to be happy, and most people have an idea in their head of what happiness looks like, what they would look like if they were happy. Um, I would guess that most people in society don't feel like they've achieved that perfect happiness. Whereas if you look at Eastern society, they, in the Far East, they don't talk about happiness the way that they do, the way that we do. They focus more on meaning, right? So they're not after happiness, they're after meaning. So there's a lot of debate about, we as humans, what are we after? Should we be after happiness or should we be after meaning, right? So there's some people that think that meaning is more important. There's some people that think happiness is more important, right? So, um, you know, we as we live our everyday lives have things that give us happiness and have things that give us meaning. The the kind of like classical example, a lot of people would disagree with the way that this is described, but the classic example of happiness is the way that you feel when you're on a, on a vacation in Maui, right? Sitting on a beach and sipping cocktails and all that kind of stuff. That's happiness. And a lot of people would describe, so that's something that provides happiness but not meaning, right?
Right.
There's no meaning in that, but it's happy. And then a lot of people describe, and a lot of people disagree with me on this, I know it, but classically, the example that people give about meaning, something that's meaningful but doesn't make you happy, is having children, right? Because it provides you meaning to help this person grow and help them become a functioning human and a happy human or whatever it is. Um, and to just kind of watch them achieve and become amazing, but it makes you tear your hair out along the way, and it makes you sleep deprived, and it makes you miserable, and you worry about them and all this kind of stuff. So it doesn't necessarily provide happiness, but it provides meaning, right?
Right.
So let me start by saying there's no correct answer to the question of what's more important, happiness or meaning, right? I think that every life needs both. I don't think that we have it right in the West, and I also don't think that they have it right in the East. I think that it's some combination of the two, and I think that what happiness is and what meaning is should be different for every single, for all 8.5 billion human beings on this planet. Everybody should define their own definitions of meaning and happiness, but I do encourage people to think as much about meaning as they do about happiness, because I think both of those are very important, right? What
Right.
gives you meaning? What gives you happiness, right?
Right. Right.
Uh, for sure. Um, I would also say that I think that if you're chasing after happiness, you'll probably find that it's not something you're ever going to achieve, right? There's nobody that is, regardless of what they tell you, there's nobody that's always happy, that lives in a state of ongoing happiness, right? So you have to define what your happiness looks like. What I'd say is I'd go back to the father of modern psychology, Sigmund Freud, and a lot of the things that he said are sort of crazy, and we don't go by them now, like infant sexuality and crazy things like that. But there were certain things that he said that made a lot of sense. What he said was that, the vision of a psychologically healthy person, and what I think is a happy person, is a person who is healthy enough to love and work, right? Look at
Right.
your life. Are you able to be productive in a positive way? Are you able to love in a positive way? Right? Are you able to do those things well and capably and enjoy them as you're doing them? I think that if you are capable of doing those things, then that is sort of as close as we humans get to this vague idea of overall happiness. That's all what we're trying to do is love and work, right?
Right.
Um, so I think that's a pretty, powerful idea. Um, in my opinion, also, I think that what leads to happiness um, is being capable of living every one thing in your life at 100%. So when I say that, I mean that if you go out to dinner with your best friend, right, and you spend the entire time staring at your phone, texting with someone else, or checking your social media, you might as well have never gone out with your friend to dinner in the first place, right?
Right.
What kind of a
Right.
way is that to live life? And it's harder to do that now than it ever has been in human history. It's harder to live your life at 100% with everything that you do, than it ever has been, because of all the distractions, and especially because of cell phones, right?
Right.
So I think, um, in our pursuit of achieving happiness, I think one of the most important things we try to do is we try to do everything that we do. We try to experience every experience, whether it's a good one or a bad one. The negative experiences too. We try to experience them fully, um, understand them, take what we can out of them without kind of pulling ourselves out of these experiences with all these tiny little distractions that make you live life at something less than 100%. Um, so that's my super long-winded answer to your question about happiness. We're trying to love, we're trying to work, we're trying to find a balance between meaning and happiness, and we're trying to live our life at 100%. What's even more important than all of those other things is when you mess all of that up, you don't get mad at yourself for doing it. You say, I'm human. I'm not going to be happy all the time. I'm not going to be great at creating meaning all the time. I'm not going to be great at not looking at my phone all day, all the time, right? That's cool. I messed it up. Let me try to do it better tomorrow, right?
Right.
Non judgment of yourself. I think that's a crucial component of happiness as well.
Right. It's a process, and you have to get yourself used to that to keep repeating the same thing. Yes.
Yeah.
So, towards now the ending, I'm going to ask: do you have any books out there? Do you have any TED talks out there? Do you see any new clients? Because I'm not sure if you see clients outside of your office. Is there a way people can reach out to you? Is your book open? What's going on?
Um, so I unfortunately am not accepting new patients. I work, excuse me, I work full time as a neuropsychologist at Boca Regional Baptist Hospital in here in Boca Raton, Florida, and I'm also a team psychologist for FAU Athletics. And I, you know, coach youth baseball, and I have a wife and three wonderful children. So I unfortunately am pretty programmed, and I'm not accepting any new patients. But with that being said, I really, really want to interact with you all on social media. That's why I created this page. While I can't really take you on as a patient via social media, I want to be here to answer your questions. That's kind of why I started all of this. That's why I kind of began this, is that send me your topics that you want me to talk about. I want to educate you on them. So yeah, I want to be with you all and help you all through this platform. I'm sorry, I'm not really accepting new patients though.
We really appreciate you. We really are happy that you are connecting with us the way you are connecting with us. When I first found the page and I saw all that knowledge being thrown at us just like that, I'm like, yeah, this is gold. So please, everybody, make sure you follow Dr. Rocky Wall. He has uh, really good videos where he gives you answers to your questions that you didn't know you had. That's pretty much how it is for me whenever I come across a video of yours. Okay, so we are going to get some questions that were asked into the chat earlier. And one of them was, what is your purpose for meaning?
Well, I'm sorry, what is my?
Okay, what is our purpose for meaning?
So let me start out by saying I think that if there was one correct answer to that question, I don't think we'd be human, right? I think we each have our own specific DNA, we each have our own thumbprint, and I think that that's part of the beauty of the human condition, is that we get to decide that, right? There's not a blueprint for that. So it's a little bit scary, but it's also a little bit wonderful. You need to decide what gives you meaning. For some people, what gives them meaning is making tons and tons of money. They want to trade in the stock market and become rich and create generational wealth so that their children are taken care of, and that's okay. There's nothing wrong with
Right.
that. Doesn't make them bad people. And for some people, they want to do medical clowning and make kids with cancer laugh, right? Kids who have such horrible pain in their lives, they just want to bring a little bit of joy, and that makes all the difference for them. And there's everything in between those two. So I don't think that there's one correct answer. And I think I'm thankful that there's not one correct answer for that. But part of the beauty of life is that you get to decide what the answer to that question is.
Great, thank you so much. Another question is, um, I am diagnosed with CPTSD, complex post-traumatic stress, and had a strong bad reaction to EMDR. What are your thoughts?
Um, so my thoughts are again that EMDR is, gosh, proponents of EMDR would hate me for saying this, but it's controversial because there is research that says it works. There's research that says it doesn't work. I'm not going to be committal on this because I think that there are a lot of people that agree in both direction. What I would say is again, PTSD, complex PTSD, and PTSD in general. Um, it's tricky because again, there are a lot of psychological problems that um, have one correct treatment, right? So, like, again, like I said, panic disorder, if you're healthy, it's exposure therapy. If a person's suffering from severe depression, behavioral activation, like just getting them moving, forcing them to eat and forcing them to walk every day, is generally the place that you want to start from. The problem with PTSD is that it takes someone with a little bit of skill to figure out what the correct answer is. Sometimes learning how to distract your mind is the way to get through it. And it sounds crazy because it's like, well, you're not dealing with the issue, you're not working through the issue, all you're doing is getting your mind off of it. Well, the research shows that works for a lot of people. And for some people, the correct answer is to expose them and to bring them back to the place where their trauma occurred and to work through it and get comfortable being there again. Um, so you can make peace with it. For some people, EMDR works. So there's not a right answer. Because you failed a trial of EMDR, it doesn't mean that you've failed treatment. It just means that of the many options that are there, this particular one didn't work for you. So don't get discouraged, right? And also, if you're a person who has PTSD, don't feel like you have to live through the trauma over and over and over again. Again, sometimes distraction is the correct treatment for PTSD. Sometimes learning to control your mind and what your mind is thinking about at any given moment and deciding, what I'd like to think about right now is my high school prom. You know what, I'm going to just relive that moment right now, and I'm going to spend the next 10 minutes thinking about what that prom was like because it was tons of fun and it was the last night I was with all my friends and whatever it was. That's 10 minutes that you're not thinking about your trauma. So that's healing. So just because you failed one treatment does not, I really don't want you to get discouraged because, that just happened to not be the one for you.
Right, right. Another question, which is my voice like sounds like a robot?
It doesn't sound like a robot. It's kind of like coming in and out, though. It's like I
Okay.
can hear it, and then it gets a little
Right,
soft, and then it.
right. I'm not sure why that is. So this is a question that actually very sensitive to me because I've been experienced this multiple times in the past 5 years. When you think you are done healing, like I feel like, okay, I reach a point into my journey where I think I'm in control of everything that is going on. A trigger shows up.
Oh,
Um,
I'm sorry. A what shows up?
a trigger, a
Oh,
trigger.
trigger. Okay.
Yes, a trigger shows up, and are I know that by now, I know that the goal is to be able to control the triggers and not let the triggers control us. And by reaching that goal, we have to identify them before they grab us. That it's understandable. But is it triggers? So from that question, I'm going to make my own little, parentheses and have my own little questions. Are triggers going to always be there for us?
I mean, it's shades of gray. Everybody has triggers. I mean, I personally, I get Sunday scaries. I love what I do. I love my job. When I get there in the morning, I'm happy to be there. For some strange reason, I still get Sunday scaries. Sunday afternoon, I'll tell you something really strange. If I have the TV on and that like 60 Minutes commercial comes on, because I know the TV show 60 Minutes is on Sunday nights, it starts to give me the Sunday scaries, and I like start to be like, ugh, another week. but then I get to work and I love my job, right? So everything is shades of gray, right? Meaning there's triggers and then there's real triggers. Like there's triggers that really throw you into a tailspin, and there's triggers that just kind of put you into not the greatest mood. What I'm going to dovetail this with is you asked me what book I would recommend for people, and I think that the best mental health book out there is a book by John Kabat-Zinn. Yes, Kabat-Zinn, Kabatzin, and the name of the book is Wherever You Go, There You Are. If you, it'll come up if you Google Wherever You Go, There You Are. Um, it'll come up. So um, the basic idea of the book, it's kind of a mindfulness book, and it's a kind of book that you can pick up and put down. It's not like one long story. It's short chapters, and every chapter theoretically can stand alone. But it's the same idea throughout. The idea is that you try to control your thinking. You try to control your thoughts. You do your best to live in the moment, right?
Be present.
Try to be
Right.
present, and you try to be in control of how your mind is working, and whether it's upset or happy or whatever. But then so that's but what's just as important as that is that when you mess that process up, which you will undoubtedly do, you you don't get mad at yourself for it. Again, it's like I said earlier, man, like I screwed that up today. Wow, like I was completely not present. Like I was feeling anxious, and because I was feeling anxious, I played games on my phone when I should have been paying attention, when I should have been doing work, when I
Right.
should have been whatever. And the idea is to not let it spiral and keep getting mad at yourself, but to say, or like I had a trigger and that trigger really threw me into a tailspin. I'm so upset with myself. The goal is to say, like, man, I messed that up. Let me try to do it better tomorrow. That's okay. Like I'm a human, and that's cool,
Exactly. Yeah.
and I'm going to try to do it better tomorrow. Like that's all right. Like this is a process, and it's the same thing with triggers, right? So everybody has triggers, things that stress you out and send you into the kind of mood that you don't want to be in, or make you anxious, or make you, um, you know, terrified, or so on and so forth. Um, for some people, it's looking at the amount of money that's in their bank account. For some people, it's having their mother call them and seeing their name on the caller ID. For some people, it's going back to the place where a trauma occurred. And then the real question is sort of, again, once that happens, how do you bounce back from it, and can you get yourself back to a place where you can effectively love and work, right?
Right.
So the trigger happens, and how far back does it set you, right?
Right.
If it sets you back some, but you can still push yourself through it and you can love and work the right way, that's not so bad. And if it sets you back so far that you can't do that, then you go the non-judgment route and you say, okay, I screwed that up pretty bad, but I
Right.
think I can do it better next time. I'm going to do my best to do it better next time, right?
Right.
So do triggers always exist? Yeah, we're human. So, I get my Sunday scaries, even though it makes no sense that I do because I love my job. But, I try to go through and love and work despite it.
Right. Right. So another question that came through, and um, I hear myself like I'm a robot. Um,
No, you sound good. It's not. It's just you sound very human. It's just
thank you. Thank you.
it's just,
Um, it's it. So I know that when you see a psychiatrist, sometimes you are on one medication and sometimes you are on two medication. Right? So we know that's possible. But what is the criteria that you guys go by? Okay, this antidepressant is not doing enough for aura. I'm going to bring another one in or another one in. How do you guys make that math with that one and that one is going to work together?
so there definitely reaches. with psychiatry and with medication management for psychological issues, there definitely reaches a point where it's more of an art than a science. And the reason for that is because, kind of like I've described earlier, you can have, two people, same age, same height, same weight, same birthplace, same parents, same life stressors, same career, and one of them comes in and you give them 20 milligrams of Prozac, and a couple of weeks later they're doing awesome. And then you take the other person that is exactly the same, you give them 20 milligrams of Prozac, and it does not help them, right? So because of that fact, it can be a lot more of an art than a science. So it really depends, and it depends on a lot of different things. It depends on whether the psychiatrist you're working with has had any specific experiences where they found that, oh, for a person that's experiencing this sort of depression, I see that they generally tend to do well with Celexa, or they tend to do well with Lexapro, right? Or if they see the person is taking a medication and they feel like they are getting a benefit from it. So let's say a person's taking Celexa, which is an SSRI, just like Prozac or Lexapro. A person's taking Celexa and they're getting some benefit, but the patient wants to see that wants to do better. The psychiatrist feels that they can do better. They don't want to take away that medication because of the benefit they've already gotten from it, right? But maybe adding something will get that person to a full remission, right? Sometimes that will be another antidepressant. So, like, for example, sometimes psychiatrists will combine an SSRI, selective serotonin reuptake inhibitor, and an SNRI, a selective norepinephrine reuptake inhibitor, because now you're increasing the activity of both serotonin and norepinephrine in the brain. Those are two chemicals in the brain that are both associated with depression. So now if I come at it from two different directions, I think I can get this person to a more full remission, right?
Right.
So it really depends on the person. If the person's getting little to no benefit, then maybe, you know what, this medication, let's junk it, it's not working. Or if they're getting some benefit, right, and I don't want them to lose that benefit, but I feel like if I add something that I can help them improve. But then taking it a step further, it's very complicated because there are many, many classes of psychiatric medications, right? There's antidepressants, which again, just within antidepressants, like I mentioned, there's MAOIs, tricyclics, SSRIs, SNRIs. And then there's antipsychotic medications. There's older antipsychotics, like Thorazine. There's atypical antipsychotics like Abilify and Geodone. There's benzodiazepines like Xanax and Ativan. So it's a very it's a complicated question that is much more of an art than a science, depending on how a person reacts to one medication. Um, because if a person has a little bit more of anxiety with their depression, then maybe a benzodiazepine like Xanax may be helpful for a little bit while the antidepressant kicks in. So it all is just dependent on the person, what benefits them, what doesn't benefit them, and what the psychiatrist's experiences and opinions are.
Right.
Does that make
Right.
sense?
Yes, that makes perfect sense. And because and this is on the sad part. I don't think, like, at least I haven't experienced this before with a psychiatrist that actually gives me a medication and actually sits face to face to me and explains to me all this. So yes, these information are very helpful. Thank you so much.
Yeah, you got it. Absolutely.
Okay. And so another question, is there a medication to help lift serotonin level?
Is there a medication to help relieve
Left, left.
lift serotonin levels? Yeah. So SSRIs, that's what they do. Selective serotonin reuptake inhibitors increase the amount of serotonin that's available in the brain. It doesn't increase the amount of serotonin that is in the brain. It increases the amount of serotonin that's available to do its job. So yeah, I'll give you a little neurophysiology lesson here. So you have one brain cell, you have another brain cell, and this brain cell spits out chemicals. And in order for a person to not be depressed, those chemicals need to do their job. They need to kind of come along and they need to attach to this cell over here, right? So these two cells need to communicate via different chemicals like serotonin and norepinephrine and dopamine, right? So this cell spits out chemicals and they're floating around. So the SSRI does not increase the amount of serotonin that's hanging out here. What it does is it allows it to stay there longer before it gets washed away so that it can do its job and connect to this cell that's kind of waiting for it. Because once that serotonin is spit out into the synapse, into that space between the two cells, there are three things that can happen to it. One is that it can come back up into the previous cell, so it can get kind of recycled and go back into the cell that spit it out. It can get washed away, or it can attach to the postsynaptic cell. It can attach to that cell, and that's what we want it to do. So what SSRIs do is they stop that process that brings them back to the previous cell so that more of it is hanging out so that it can do its job. So the SSRI, which is the most commonly prescribed antidepressant on the market these days, that's exactly what it does, is it increases the amount of serotonin that's available to do its job.
Right, right. Thank you.
You
And then
got
we
it.
have it's exercise good for trauma recovery.
I'm
And
sorry, is
it's exercise good for trauma recovery. And what I want to push this question through with, it's through like an explanation of what exactly happens in our body and brain when we exercise and why it's helpful for our trauma recovery, depression, and anxiety.
okay, awesome. Exercise is good for everything, everything,
Right.
everything. When I say exercise, so the research shows that 30 minutes of like light to moderate exercise, I mean going for a walk, right? Like I don't mean like running, jogging, hard elliptical or anything like that. You go for a 30-minute walk 5 days a week, that is just as effective as antidepressants. And if you stick with it and you keep doing it, you're less likely to relapse. So
Right.
exercise is good for everything. It's good for trauma. It's good for depression. It's good for anxiety. It's good. It's good for it's good for brain injury. It's good for stroke. It's good for everything. Everything. I cannot stress that enough. Please go for a walk. Go for a 30-minute walk every day, please. What happens in your body when there's a million things that happen in your body and your central nervous system? So I'm sure a lot of you have heard of runner's high, right? So um, a lot of chemicals that people put into their body through drugs, right? A lot of times those chemicals already exist inside your body. You're just putting more of them inside. So there's a term for that. There's endogenous, which means that the chemical comes from inside your body. And there's exogenous, which means that the chemical comes from outside your body. So if a person, for example, puts heroin or Percocet and they abuse it, they're taking exogenous opioids, they're taking exogenous narcotics, they're putting it in their body, right? But there's an endogenous equivalent to all of those drugs that people take. In other words, your body essentially has heroin in it. It's not heroin, right? They're called endorphins and enkephalins, right? But they're your body's version of heroin and Percocet. Basically, they do the exact same things, right? They work with all the same receptors in your brain, so that heroin that people put in their bodies work on the same receptors as these endogenous chemicals, these enkephalins and endorphins. So when you've heard of runner's high, when a person runs and they get like this feeling like they're high afterwards, that's actually what they're feeling. They're feeling sort of like an opiate high, right? Because what they're doing is they're kicking up those endorphins and enkephalins and starting to get them to work. It makes them feel good. It makes you feel better. right? It relieves pain, if you can believe it or not. So runner's high is a real thing. And actually, for competitive runners, when they run and run and run every day for months, years, and then they become injured and they suddenly can't do anything, they actually can experience withdrawals, sort of the same way that a person who's addicted to heroin experiences withdrawals. Not quite as dramatic, but it's similar when they all of a sudden can't run because their body isn't getting those endogenous opiates anymore. So when you move, you are literally making your body and your mind feel good. You're relieving both emotional and physical pain. Um, that's like the short version of all the incredible things that happen to your body when you move. So um, just yeah, it there is you would be challenged to find something that exercise is not good for. So please move, move, move. Everybody move. Movement is life.
Right, right. I do. I just love the way you explain in such an engaging way. You're doing awesome. Love
Thank
it.
you.
Um, Another question: have you heard of past life regression?
Past life.
Yes, yeah.
I don't think I
I
have.
okay,
I don't think I have. If someone wants to
okay.
tell
All right,
me
we move on.
more about what it is, then I might be able to speak to it more. But I don't think I've ever heard of that.
Can you tell me what it is? Because I'm confused. I don't know what it is.
That's the first time I've ever heard that term.
Okay. All right. We're gonna let this one go. We're gonna ask another question. We have many, and I actually have
I
two
got it.
questions.
I'm here. I'm
Okay.
not going anywhere.
All right. I have two questions of on my own that I'm gonna let them towards the end. Okay. With with borderline personality disorder, misdiagnosed, does the person feel multi personality?
I'm sorry. With borderline personality, when the person.
Okay, so a person that has a borderline personality disorder that was misdiagnosed, the person feels multiple personalities? Question mark.
Does the person have multiple personalities? Is that what the question was?
Yeah, I think so. Yeah.
No. So what we call multiple personalities these days, the disorder in the DSM, like I described earlier, the DSM, the Diagnostic and Statistical Manual, what we call it is dissociative identity disorder, um, which used to be called multiple personality disorder. I will tell you that in my career, I would feel comfortable saying that I have seen people with every single disorder and probably every single disorder in the DSM, maybe with a couple of very rare exceptions. I have never seen anyone that truly had dissociative identity disorder or multiple personality disorder. I've never seen it. Never seen it.
Okay.
It doesn't
I
mean it doesn't mean it doesn't exist, but there are a massive number of psychologists and psychiatrists that do not believe it exists, and then there's a lot that do. So I'm not saying necessarily that I think it doesn't exist. I can just tell you that I've never even had a patient claim that they had it. Borderline personality disorder is something very different. Borderline personality disorder is. Can I take a second to like
oh
explain
yeah,
more?
take it. Of course, please do
Okay.
that. Please.
So in the old DSM, the DSM-4, we used to separate psychological disorders in general from personality disorders. The reason for that being is that, and I hope this is encouraging for people, is that most psychological disorders are things that people can go into and heal and come out of, right? So, in other words, most people don't stay depressed their whole lives. They get care and they get better. So, you go into depression, you come out of it. Same thing with panic disorder. You know, a person experiences panic attacks and they get help and they get better and they come out of it. Same with schizophrenia. A lot of people with schizophrenia get better and heal. Um, the reason personality disorders in general are separated is because the theory is that personality disorders are like woven into the fabric of who you are. So if a person has a personality disorder, it's not, in other words, we like to say, that is a person who has depression. It doesn't define you. You are a person, and depression is something you're suffering from. But with personality disorders, the theory really was that it's woven into the fabric of who you are. And separating that out, while it's not impossible, is extremely difficult and takes a ton of insight and a ton of work. Um, Among personality disorders, probably the most dreaded personality disorder and the most stigmatized is borderline personality disorder. Borderline personality disorder is the hallmark of it is splitting. Splitting means that a person's thinking is that people are all good or all bad, right? So psychologists dread having people with borderline personality disorder as patients because people with BPD will, you know, tell you they're in love with you one day and try to sleep with you, and then the next day they'll leave a message on your answering machine saying that they're suing you, right? Because you're either all good or you're all bad, and there's sort of like no in between, right? It can go back and forth from one to the other, or it might stay all with one. In your work, a lot of you have probably come across people with borderline personality disorder. Sometimes you'll see very malignant people with BPD who are in positions of power, and they decide that there's someone that is under their management they don't like, and they just go after them. They just ruin their lives, and they cannot rest until that person has been let go, is miserable, or everybody else in the company thinks that that person is miserable. That's a kind of thing that a person with borderline personality disorder does. Another thing, obviously, being in a relationship with a person with BPD is extremely challenging. Other hallmarks of borderline personality disorder, people with BPD tend to cut. Um, so they tend to, engage in non-suicidal self-harm, like cutting themselves. They also tend to engage in histrionic suicide attempts. So they will attempt suicide in a manner that would not realistically end in a completed suicide for the purpose of trying to get attention. Not attention like, look at me, but attention like, help me kind of attention. So borderline personality disorder is very, very different from dissociative identity disorder slash multiple personality disorder, if that makes sense.
Right. Yes, it does perfectly. Next question is, what are your thoughts on trauma-informed yoga?
Love it. Love it.
Can you tell us a little bit about it because I don't know much about it.
It's like a combination between yoga and therapy, right? So it's it can be talking through your issues, your trauma, getting treatment for them while you engage in movement. And I think that the combination of movement and therapy is a great thing. I also think it can be very effective if you do the yoga and therapy separately, but yoga involves a ton of mindfulness, right? So the goal in yoga is being in control of your thoughts, right? And giving them 100% of your attention, whether that thought is like downward facing dog, or whether that is, you know, the heat inside of hot yoga and the amount of sweat you're, pouring out or anything like that. The goal in yoga is really to focus 100% of your energy on what you're doing. So I think that's very, very beneficial for people to learn that skill. To be in control of your mind is a very, very beneficial skill.
Right. Um, so speaking about yoga, my first experience with yoga and my last experience with yoga, I wasn't yet diagnosed with depression, and my mom did not pass away. So it was right before everything happened. And I went to a yoga session, and the yoga session was about connecting with the body. I cried the whole time, and I had to go to the bathroom and cry some more for two reasons. I was crying because I was sad, and then I was crying because I was scared. I didn't know why I wasn't crying. Now, looking at the situation from where I am right now, I totally understand what happened then. But I have no clue that that can be so powerful. I haven't yet gone back to yoga because that memory is still in my head, but I do have it on, in my future plans, definitely.
Good. I think that's great. I think that will be a great achievement for you and a great sign of growth when you can get there.
Right, right. Thank you so much. Another question is, what is a mixed personality disorder?
So, mixed personality disorder, like I was discussing earlier, so the personality disorders are differentiated from other psychological disorders because they're really kind of like woven into the fabric of who a person is, and they're much harder to kind of like shake, like get rid of. Most people, the theory is, suffer from personality disorders for their whole lives. So there are several personality disorders. There's borderline personality disorder, which we've discussed. There's narcissistic personality disorder. There's schizotypal personality disorder. There's schizoid personality disorder. There's obsessive compulsive personality disorder, which is very different from obsessive compulsive disorder, right? So it goes on. And mixed personality disorder is when a person has more meets criteria for more than one of those personality disorders.
Right, makes sense. Yeah.
Good question.
Right. Yes, very good question. Um, Next question. We are human beings, and as such, we are emotional beings. The medication makes me feel numb and emotionless. Is that what these medications are supposed to do?
No, that's never the goal. Um, the goal is to be able to feel the full range of emotions when. So, unfortunately, I don't know what medication she's referring to. I'm going to go under the assumption that she's talking about SSRIs because they're by far the most commonly prescribed group of psychiatric medications. The goal is to experience the full range of human emotions, joy, anger, sadness, etc., minus clinical depression. That's the picture of successful treatment. So there's a lot of answers to that. Please do not do anything without your doctor say so. But from that point, there are a lot of options. It could be that a lower dose of the medication could help with that. It could be that if you stick with it, that will improve. Because most side effects that go along with antidepressants get better if you stick with the antidepressant for longer. Or it could just be that that particular medication doesn't agree with you.
Right,
So
right.
no, that's never the goal. You don't want to feel numb. That's not what we want. We want you to be um, a fully functioning person with a full range of emotions, minus clinical depression.
Right, right. She was talking about the Wellbutrin and Prozac.
Which one?
Wellbutrin.
And
That's
Prozac.
what.
Right. So Wellbutrin is an SNRI, selective norepinephrine reuptake inhibitor, which does the same thing as the SSRI, just with norepinephrine. It leaves more norepinephrine available for the brain to be used by the brain. Um, Norepinephrine, dopamine, and serotonin are the main chemicals that are associated with depression. So you can see what the doctor was doing. So Prozac is a selective serotonin reuptake inhibitor. Wellbutrin is a selective norepinephrine reuptake inhibitor. So what the doctor is doing is coming at it from two sides. I'm going to help this person by increasing the amount of two different chemicals in their brain that are associated with depression. The goal is not to feel numb, but what I would obviously talk to your doctor because there's a million things about your situation obviously that I don't know. But a lot of times with these things, if you either decrease the dose or if you just stick with it, that gets better.
Right, right. Thank you so
Antisocial
much.
personality disorder, I saw. We'll get to that when it's time for
Yes,
that.
yeah, it's getting noted there, I believe. Um, what would you recommend for a psychology student once they get their bachelor degree?
Okay. It depends. It depends on your tolerance for school. If you love school and you can handle it and you can imagine yourself being a psychologist, then go for it. If you want to work in the field but you don't quite have the stomach for all that school, you can become a social worker or a mental health counselor. Unfortunately, you can't do a ton in terms in the mental health field. You can't do a ton with a bachelor's degree in psychology. But I would say it's just really a question of how much school you think you can handle and how much you love psychology.
Right, right.
That's what I'd
I mean,
say.
right. I'm taking that path myself too, and trying to make decisions. What is best, going to school and also having a full time job and also being a single mom. It's like you have to take all that in consideration to decide is it time to go now or do something with what you have with the bachelor's degree and then later go into school. And I'm gonna add something to this question. Is there places that if you come in with a bachelor degree, they will help you to further your education and they will help you financially? Is there such a like places that will help you with that?
That will help you like do master's degrees.
Yes, for example, I'm going with a bachelor degree. I'm going to get a social, what is it? A social worker, right? Job. Will there be places that would be like we wanted to get a degree, uh, just go and get it and we'll pay for it? No, no,
I would say
maybe.
unless you work for a company that pays for education, that pays for graduate credits, I'm not familiar. Unfortunately, clinical psychology is very competitive.
Right,
Unfortunately, the doctoral program. So a lot of times people go and do separate So if you go straight from college into a PsyD, a Doctor of Psychology program, or a PhD in clinical psychology, which are basically more or less equivalent degrees, um, you get a master's along the way, right? So as part of the program, after at the end of your second year, you usually have a master's degree. But a lot of times people can't get into those programs because they're not competitive enough. So sometimes people will get a separate master's, a terminal master's degree, so that they're a better candidate for a doctoral program.
right,
Yeah.
right. Thank you so much for your answer. Um, who is the best person to see for PTSD and autism?
For,
Like what psychologist or what kind of doctor would be most beneficial for the person that has complex post-traumatic stress and autism?
so CPTSD and autism.
Right, right,
Um, I mean, I think that look, there's obviously a lot of things I don't know about that other, than reducing a person to a diagnosis. It's hard, but what I would say is that I think that the PTSD, you'd probably want it to be treated by a psychologist that's experienced with trauma. But autism, people with autism tend to do well with social groups and interaction. So unless they have what's called level 3 autism spectrum disorder, which is more severe autism, they tend to do better with social experience so that they can kind of learn what people react well to and what people don't react well to, and kind of get used to the idea of being in social situations and what's acceptable and what's not. Um,
right.
yeah, that's what I'd say is that the PTSD side of it, you want a psychologist that's experienced with trauma, and then the autism side of it, you want social interaction, like social
Right.
groups,
That
that
is
sort
a
of thing.
good, yeah, that's a good answer with the information that you had.
Yeah, that's what I'd
Yep.
say, but it's a good question.
Right, it is. Can bipolar depression diagnosis be confused by trauma? This is a really, really good question because I think that's happening and has happened. So, can somebody with can somebody with bipolar depression diagnosis be confused by trauma?
Sure, definitely. Um,
No, no, not confused. I'm sorry, I read it wrong. Can bipolar depression diagnosis be caused by trauma?
okay, so
That sounds better, right?
yes, so it can. The way to think about it is that bipolar disorder is usually has a very strong genetic component to it, right? So if you have a person in your family, the closer they are in terms of their relativity to you, the much more likely you are to have it. So, for example, if you have an identical twin that has bipolar disorder, you have, I forget what the exact number is, but you basically have like a 50-50 chance of having it yourself. So, if you have a person who has some kind of a predisposition towards bipolar disorder, and then they have a stress, right? They have a biological predisposition, it's in their DNA, then something stressful happens like a trauma, right? That can be the trigger that leads to the first depressive or manic episode of bipolar disorder, which kind of sets the whole disorder into existence, right? It makes it express the DNA. So, absolutely, yes. Trauma can be the trigger for bipolar disorder, yes.
Right. Thank you. What is antisocial personality disorder?
Good question.
Yeah.
Antisocial personality disorder is a person who essentially um, does not have any problem violating the rights of other people in order to gain what they want. Another personality disorder, right? So again, it's kind of woven into the fabric of who a person is. These things tend to not get better unless the person has a ton of insight into them. Um, so more often than not, it's kind of for life. When people get better from it, it's not that they magically start to care about other people's feelings. It's that they understand how the world works and they understand they can't go on violating other people's rights. So so that's a diagnosis, antisocial personality disorder. What's not a diagnosis, but it is frequently used to describe people uh, with APD is sociopathy and psychopathy. So a sociopath or a psychopath, right? So sociopaths and psychopaths have antisocial personality disorder. The difference between simple way to remember it: a sociopath is hot-blooded, psychopath I'm sorry, sociopath is hot-headed, a psychopath is cold-blooded. So a sociopath is someone that gets mad, loses control of themselves, and would, let's go to an extreme, would murder someone because they're angry and they want what that person has. A psychopath, if you guys have ever watched Dexter, that's like the perfect example of a psychopath. There's zero feeling to it. He's not
Right.
angry. He's not anything. He just wants to punish people. So
Right.
he gets them alone and tortures them and then murders them.
Yeah.
So that's a psychopath. Perfect
Right.
example. There's no emotion to it. With sociopath, there is a lot of emotion involved.
Right. Is there a happening to be like a mix in between them two and meet the middle part and be something else?
I'm sorry.
Like, can these two disorders can they be combined for some people and something in the middle be something else?
Yeah, absolutely. I think there's probably most people that have APD have some features of both psychopathy and sociopathy, meaning there are things in their life that trigger a lot of emotion for them, and there are things in their lives that they're completely emotionless about. Like they may you know, let's go to like a real extreme, right? So you could have a person with APD who would murder a loved one if they angered them the right way, and there would be a lot of emotion involved in that. Or they could also, they could fire an employee for no good reason and not feel a thing about it, have it be a completely emotionless thing. So there's a lot of interplay between the two. Yeah.
Right, right. I just love the way you explain things. Are you a professor as well? Like, do you
So
teach?
so we do so at Baptist Health. I work at Marcus Neuroscience Institute, which is a big neuroscience center. I work as a neuropsychologist there. So I'm a faculty member of the neurology department there, but I'm also um, a an affiliate faculty member of the FAU College of Medicine. So we teach the neurology residents. Um, so I've done, yeah, I do a lot of teaching too, but I appreciate it. Hey, we can do this again. I'd be
Oh,
happy to do it.
definitely. We are going that. That's of course that's a giving. That's not even a question.
Good.
Um, so, do you have time for like three more questions?
Let's
Is
do
that
it.
cool?
Sure,
All
let's
right.
do it.
Can you explain dissociate DID, dissociated identity disorder?
Yep. DID again. That's multiple personality disorder, and there's a lot of controversy around DID. Again, there's a lot. Like I've said, I mean, there's over 300 disorders in the DSM, and I'm fairly confident I've seen almost every single one of them, if not every single one of them. But I've never seen a person. I've been licensed for about 15 years. I've never seen a person with DID. I've never even seen a patient who claimed they had DID. Never seen it. Person with multiple personalities. No.
Right. Right.
Again, it doesn't mean it doesn't exist, but I mean, I would say people that are that feel pretty strongly against it would say that when they do see it, it's faked. But
Wow.
I don't know. It's tough to say. I've read a lot of research about it, and people feel pretty passionately in both directions. Um, I guess think about your daily life. Every single one of you has come into contact with people that are depressed, people that are anxious, probably even people that are psychotic at times, but at least maybe once or twice in your life. But have you ever come into contact with a person that claims they have multiple personalities? I don't think I ever have.
Yeah, I have not face to face, but through the platform.
Right.
Um, I'm going to ask two questions because I think we actually went through all the questions that were asked in the chat. So I have two questions on of my own. Um, First question: it's a very sensitive subject to me, and I think that it's not talked enough. And people that suffer from an eating disorder, such as anorexia nervosa, which is uh, the number one mental illness that it's very damaging to your body and to your mind, and it just removes you off this earth. Uh, and I know that it's so hard because the battle is not only with us, but it's also with the society of how they claim the healthy, right? And it's also a battle with the hurry up, have the perfect looking body type of thing. So it's a lot of components into that makes the survivor make the steps like there's rocks, literally rocks on our legs. Would you be able to tell us what is anorexia nervosa and um, how can one look for treatment? Although I know it's very hard because at some point you have to look sick enough to actually get a bed in a treatment center, right? And some of the insurances doesn't even agree with that. So is there anything you can tell me about this? Anything at
Sure,
all?
sure. Um, I will be honest with you, eating disorders in general, anorexia and bulimia can be really tough. They can be really, really tough. Anorexia, by definition, means that a person restricts their food intake. And in order for a person to have anorexia, they need to have a body weight which is 15% below what is normal for them given their height, right?
Right.
So a person needs to be pretty darn underweight and they need to actively restrict their food intake. And most times people do this because of the fact that they think they're overweight, and it, it's a very tricky issue to deal with because of the fact that most times, again, you're talking about a person that, in order to meet criteria for anorexia, has to be significantly underweight, right? So it's a person that is significantly underweight, but they're having a hard time seeing that they are underweight. So that can be
Like
a
how body dysmorphia kind of thing?
exactly right.
Right.
Yeah, exactly right. Sort of, there's like a body dysmorphic disorder kind of component to it. Um, so essentially, they're not seeing reality the way that other people might see it, right? So in other words, if a person was 15% under normal weight, and you were to line up 10 people and have those 10 people look at the person, they'd say that person really needs to put on some weight. They don't look healthy. But that person looks at themselves and says, I'm overweight, I'm fat.
Yeah.
And even when faced with evidence, look at your BMI. Your BMI shows that you're significantly underweight. The
Right.
person still says, well, I mean, look at me, I'm fat. Like I have big thighs, I have big hips, I have a big stomach. So it's a very difficult thing, but if you kind of look at it, the underlying component of it that you're trying to fix is the same as an anxiety, right? So with anxiety, a person does not see a stress the same way that they see that it really exists in the world. By definition, anxiety, you're worrying about something more than you need to, and the goal is for them to just see the world the same way another person who's not anxious would see it. So the goal with a person with anorexia, by the same token, is just to have them see themselves the way that everybody else sees them, right?
Right.
In a realistic way.
Right.
Um, so it can be a real challenge and it can be very stubborn. The earlier you get to it, the better.
Right.
Um, and getting treatment for it, yeah, typically if it's to a point where the person really is underweight, um, they tend to do better in residential facilities, and it can be difficult to get yourself into a residential facility for a lot of reasons, insurance and space
Right.
and all this kind of stuff. But specifically, it's important to get into a facility because, um, A, they can, if you're underweight, you're putting yourself at risk for other medical conditions like amenorrhea, which means you're not having your period because you're not getting enough nutrition,
Right.
or early onset osteoporosis, which is really dangerous, right? If you have early onset osteoporosis, it means your bones become brittle at a very young age, the way that, like an 80-year-old person's would.
Right.
Um, so you really need kind of like that team of care, making sure you're getting nutrition and that
Right.
you're getting all the care and attention that you need to kind of get things better so that they don't spiral. Um, in terms of finding a facility, um, there's no magic bullet for that. It's you need a you need to work towards it, and if you don't have the means to do it out of pocket, then you have to really push for it with your insurance and push for it with the facility. And if facilities don't have room, you have to keep looking, because the research shows that people with eating disorders do best in residential facilities until they're better.
Right. Right. and it's one thing that you point out that I stopped for a minute and I'm like, oh. Um, I was talking with my therapist, and she mentioned that eating disorder is an anxiety disorder, right? And let's say, I'm gonna tell you, I closed the door to that in her face right away. I'm like, no, it's not, just because um, I am a survivor of anorexia. I've been in recovery for 3 years. I restore my body weight, and I'm good now. Of
Good for
course, it's a
you.
battle. It's a battle, but I am walking this path, and I'm aware of the damage to my body that anorexia can do. So it's not easy, but I'm doing it. Every day it gets better. But it's funny because when you said anxiety disorder, I'm like, oh my God, she was right. Right.
It
So I will have to tell her that.
it
Uh,
is sort of like that. It's like that you're not, it's like a person doesn't see things the way that other people would see them, you know?
right. 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 I mean, for me, it was very extremely difficult to even come to terms with the fact that this is what I am against this. And I'm sure that a lot of people doesn't know that there is more than one eating disorder, more than just bulimia and anorexia.
Yep,
There is, if I'm not mistaken, 8 to 10 types
that's
of
correct.
eating disorder that is not talked enough about it, right? And I also know that anorexia is anxiety disorder. I'm gonna call it that now. That helps you control things that are out of your control, and this is the way we control things.
Yeah.
Um, so yeah, I think I touched all my points, and I cannot. I don't think I have good enough words to tell you how much I appreciate this life, like how much information you have given me, and your time is very much appreciated by me and by everyone in here. And I hope that we are going to do this again. We have to. We have to do this again soon.
You tell me when. I would love to. It was a lot of fun. You have
Right.
great followers.
Thank you. Yes, I am. I'm locking up. I don't have any negative part on this platform. I have a good group of people, and yeah,
Thank you
right.
so much, Aura. This was so much fun, and I love your openness and your willingness to talk about your experiences because I'm sure that that helps your followers tremendously.
Of course, and I think that me by sharing, a lot of times, like when I put the video out there and I tell everybody, I am learning at the same pace my viewers are learning. Like I put out a video, I'm like, okay, that makes sense. Let's put it out so other people can see it, and that's how I help myself, and that's how I learn too. And it's been a TikTok has been an important tool in my toolbox of recovery, definitely, and I'm grateful for that.
I'm so glad to hear that. That's amazing. Look, that's the goal, right? Is for social media to bring positive into the world and not negative. That's
Right,
what we want it to be. It definitely brings a lot of negative, so I'm really happy that it's bringing a lot of positive too.
right, right. So thank you so much for your time, everybody. Please follow Dr. Rafi Wald. He is amazing. You guys will get a lot of good information, and I hope we do this soon again. Okay.
You let me know. I'm ready.
All right. Enjoy your weekend. Bye bye,
Thanks,
guys.
Laura. You too.